Okay, thank you for the invitation. My name is Daniel Gunther. I'm from Cologne, Germany, and I will talk about bony ACL avulsions from diagnosis to treatment. But first of all, thanks to the president, to the vice president, and the past president for organizing such an amazing meeting in such a beautiful city. It's really an honor to me to be here. These are my conflicts of interests. And much more important, these are my kids. And when I prepared the presentation, I got a little bit afraid because typically such injuries affect children and adolescents aged 8 to 14 years old, right? So on the left, that's my daughter. She's 7 years old now. So hopefully she's doing fine during the next couple of years, right? But then I became less afraid because the incidence is only 3 per 100,000 patients per year. So you have to believe me, I don't have so many kids, so I'm less afraid. What about the injury mechanism? Usually it's a tibial rotation mechanism with the knee in mid-flexion, but also the trauma can be hyperextension of the knee. Then we have in MRI this bony edema of the anterior cortex of the femoral bone, or of the anterior part of the tibia. And those are the main injury mechanism for bony ACL avulsions. If such a patient presents to your outpatient's clinic, then Peter just talked about it, the clinical examination. If you have an ACL injury, usually you have a positive Lachman test, you have a positive pivot shift test, right? But in an ACL avulsion, that doesn't necessarily have to be the case, because you have the fragment, it can impinge, it can stick there in the femoral notch, and sometimes the Lachman is quite stable in those patients. And usually those injuries are acute injuries, and so some patients are afraid of having a pivot shift conducted on their knees, so maybe you cannot do a pivot shift. So in most of the patients, they present with an extension deficit, because it's painful for them to extend the knee completely because you have this fragment there in the notch. And that is maybe one really important sign in the clinical examination. The next thing is then the imaging tools. So first we will perform X-rays, AP and lateral view. And in most of the cases, you can see the fragment there on the tibia. Then we always do a CT scan just to see if it is multifragmentary or if it is just one big fragment. It's important to make a planning for the surgery, right? And also, we always perform an MRI scan. And that's important to see if you have any concomitant injuries to the menisci. Sometimes the meniscal roots are attached to the fragment. That's important. It's also important to take a look at the CT scan and MRI scan to see if the medial or lateral tibial plateau are involved. And then you should take another look at the ACL itself. If you have an additional edema in the ACL, additionally to the avulsion, this is a high-risk patient for failed refixation of the ACL avulsion. So about 10 to 15% of patients need ACL reconstruction in the further course, and those are mainly patients who have a partial rupture of the ACL or edema in the ACL in the time of injury. I think all of you know this classification from Myers and McKeever. It's quite old, right? So you have the type 1 lesion where the fragment is still in place, non-displaced. Type 2 lesion where we have a partial displacement, usually less than 2 millimeters, right? Type 3A, where the fragment is displaced and it involves usually only the ACL. And in type 3B, you have involvement of the whole eminentia. And type 4, this was added later on, back I think in 1977. This is when you have multiple pieces of the fragment and you should treat them maybe differently. I will talk about it. This is a paper performed by one of the guys from Andreas Imhoff groups, Matthias Feucht, and he took a look at concomitant injuries during ACL avulsions. And there's a high rate of meniscus injuries, up to 40%. I mean, you can see those soft tissue meniscus injuries are mainly on the lateral side, mainly on the posterior horn of the meniscus. But there are still some guys who say, oh, it's a fracture, so you should treat them with an open approach. But if you would do that without using arthroscopy, you will definitely oversee such injuries. So for me, you can absolutely, or you should absolutely treat them arthroscopically, and definitely should take another look at the menisci. But it's not only meniscus soft tissue injury. If we take another look at the ACL insertion here, you can have the avulsion fracture right at the insertion site. But in a lot of cases, as we said, you can have the meniscus root involved. And this is important to see because sometimes it gets more difficult to get them down arthroscopically then, especially if you have the lateral or medial tibial plateau involved. And those are cases, sometimes I use a mini open approach as well, just to put it down and reduce it completely. And based on all these things, a new classification was done by Green back in 2019. And the grade 1 is mainly non-displaced fracture. Then we have grade 2, where you have like a hinge on the posterior side because of the ACL forces. And then you have, interestingly, grade 3, where you have either a displacement, a complete displacement, or, and that's an important thing, the meniscus can impinge underneath the fragment. And not only the meniscus, also the transverse ligament of the meniscus can impinge underneath the fragment. And then it's extremely difficult to reduce the fragment. And on the right side, you can see what I mentioned. If the medial or lateral side of the plateau are involved, then it can be difficult as well to treat it with an all arthroscopic approach. Sometimes you need a mini open approach to reduce it completely. Here you can see such a transverse ligament, and this is already reduced. But you can imagine sometimes the transverse ligament impinges underneath the bony fragment, and then it's difficult to reduce it, so you first have to get it on top of the fragment again, and then you can reduce the fragment. This is our treatment of choice in Cologne. What we do with the transverse ligament, we just use a knee scorpion and just suture the ligament, and then you can pull it anterior, and you have a beautiful view on the fragment and the ACL stem. And then we just use some wires. Put one wire on the left side of the ligament, one wire on the right side of the ligament, so one medial, one lateral wire. We don't even over-drill them, we just use the wire. And it's important to make sure that you completely grab the stem of the ACL then with a tape. You can either use a knee scorpion or a first pass mini, whatever company you're working with. And then we use a tape, put it through the ACL stem, and then we just use a spinal needle with a PDS suture. That's the reason why we don't have to over-drill the wire. We take the tape out, first on the lateral side, and then with another spinal needle here on the medial side. Grab it out, and then you can pass the tape through the tibial bone. We usually fix them on the tibial side with either a button or a push lock anchor, works well as well. And then in most of the cases, we use a second tape, more anterior, to reduce it completely. Again, one medial and one on the lateral side. And then you can, because the forces are then in an anterior direction, this is, in my opinion, a little bit more anatomic than if you put some screws in, which go usually to the posterior direction. And you can take out the tape, and you can see that you can, if you pull on the tape, you get a lot of pressure on the fragment, and you can reduce it completely. Most of you will say another good option are screws, cannulated screws. This is not my patient because I don't like those screws so much. I mean, you can achieve a good replacement of the fragment for sure, but especially patients who hyperextend their knee can have some cartilage damage in the notch. It's sometimes really hard for them to extend the knee. You definitely have to remove it after a couple of weeks. So I don't use those screws. If I want to use screws, especially if I have a bigger fragment, I would go for magnesium screws. You can see it on the right. They are completely resorbable, and I can hide it underneath the cartilage completely, so I won't get cartilage damage in the trochlea. And that's my choice if I want to use a screw, and they are cannulated as well. If we talk about post-op treatment, if you take a look at the literature, there's a lot of different treatment regimes, and mainly case series, not a high level of evidence. My treatment of choice is 1st to 6th week, I put them in a brace. The first 2 weeks, I let them partial weight bear with free range of motion. I know a lot of people say they have to extend their knee for a certain time, but the reason for that I don't want to do it is, if you take a look at the ACL, usually it gets slack if you go to full extension. It gets slack if you go to bend the knee, and you get more forces on the ACL if you go to extension. So I let them move their knee completely free, but I want to prevent that they rotate their knee. So that's the reason why I put them in a brace, because there are a lot of forces on the ACL. They're going to rotate the tibial bone. But I don't really think that you have to limit the range of motion in extension, because as we all know, in extension, the ACL is very tight usually. So this is the team behind it back in Cologne. I'm very proud of all these guys. It's a great team. They're supporting me a lot. And next year, February 27 to March 1st, we have the next World Surgery Tour Festival in Cologne. A lot of life surgeries, innovation symposium, hands-on courses. Please feel free to take a look at the homepage. Please feel free to register. Andreas Imhoff will be involved. I will be involved. And thanks again for listening, and thanks for the invitation.